Welcome to the anatomy of the cardiovascular and pulmonary systems. This is just the objective slide, things that we're going to cover between this voiceover PowerPoint and things that we're going to cover in lab. So explaining the anatomical movement of the thoracic wall. We're going to talk about how the thoracic wall moves during inspiration and expiration. You're going to look at all the bones, the muscle, the tendons, ligaments, arteries, and veins of the thoracic wall. You're going to talk about the proximal and distal attachments of the muscles of the thoracic wall. This one's kind of a review, as Dr. Torres already covered this one. We're going to talk about the unilateral and bilateral actions of the major muscles of the thoracic wall, more so in class on Friday. Want you to be able to identify the major peripheral nerves, those internal intercostals, and some of the arteries and veins of the thoracic wall. We're also going to talk a lot, and the majority of this talk is going to be focused on the organs. So we're going to talk very in-depthly about the heart and the lungs, and we're going to discuss age-related changes that we see across the lifespan. And then I'm going to give you guys two case scenarios of a cardio patient, pulmonary patient, and we're going to use anatomical principles to go over the plan of care and the overall treatment and some of the complications that you may see in these patients. All right, we're going to begin the anatomy of the cardiovascular and the pulmonary systems talk by talking about the thorax, which is the bony covering which protects the major organs of the cardiopulmonary system. So as you know, within the thoracic cavity, we have the heart, which is housed within the mediastinum centrally, and then also we have the two lungs, which are located a little more laterally. So the bony thorax is what actually provides the skeletal framework for the attachment of the muscles of ventilation. And this picture here shows the thoracic cage. So the skeletal boundaries of the thorax are the 12 thoracic vertebrae dorsally, the ribs laterally, and the sternum ventrally. So now we're going to get into talking a little more about the sternum, and we're going to break it up into the three different segments. The sternum is also known as the breastbone. It's a flat bone with three major parts. First, I'm going to go over in red right now the manubrium. So what I'm going over right now is the manubrium. This is the thickest component of the breastbone, and it articulates with the clavicles and the first and second ribs. There's also a palpable jugular notch or a suprasternal notch, which is found at the superior border of the manubrium of the sternum. Let's go a little bit inferior now, and I'm going to highlight this area in this orange color. Not the best tracing, but you see what I outlined. The manubrium is the body of the sternum, and it articulates laterally with ribs number 3 to number 7. I do want you to pay attention to what is known as the sternal angle, also called the angle of Louis. So the angle of Louis is the anterior angle that's formed by the junction of the manubrium and the body of the sternum. So I'm going to circle that area in black right now. This is the angle of Louis right here at the junction of the manubrium and the sternum. So this structure is very easy to palpate. It's in level with the second costal cartilage anteriorly. And then you'll also see it when I flip slides and we look at the thorax from the posterior view. It's in line with the thoracic vertebrae T4 and T5 posteriorly. And then at the very tip, the most caudal aspect of the sternum, which I'm circling now in a lighter red color, is known as the xiphoid process. And this is just a plate of hyaline cartilage that ossifies later in life. So going back real quick to the angle of Louis, what I want you to know about that is that it marks the level of bifurcation of the trachea into the right and the left main stem bronchi. And it also provides that pump handle action of the sternal body during inspiration. And remember from pathophys, we're going to talk about this later on, how the trachea bifurcates and which main bronchi is shorter and wider, and which is more likely to have an object aspirated in. So for instance, this comes into clinical relevance in the pediatric setting, little kids are always putting things in their mouth, they're always swallowing inanimate objects. So objects are more likely to get stuck in the right main bronchi because the right main bronchi is shorter and wider than the left one. Another pathology I want you guys to be familiar with is known as pectus excavatum, or the caved-in chest. This is a common congenital deformity of the anterior wall of the chest, where several ribs and the sternum are growing abnormally. And as you can see from the picture here, this produces this caved-in or sunken appearance of the chest. It's usually present at birth, but it rapidly progresses during the early years of bone growth, especially in those prepubescent teenage years. And as you can imagine, as the chest is caving in on itself, there may be a lot of pulmonary and cardiac complications. So these include shortness of breath caused by the altered mechanics of the inspiratory muscles on the caved-in sternum and ribs, and the heart is basically restricted, so it's going to have an altered pumping mechanism to it. So it's going to be more difficult for the heart to pump with this pathology, pectus excavatum, existing. Now we're going to move into talking about the ribs. So even though they're considered to be flat bones, the ribs actually curve forward and downward from their posterior vertebral attachments toward their costal cartilages. So on the left side of the screen, you see the anterior view, and on the right side of the screen, you see the posterior view. So I'm going to go over the anterior view first, and I'm circling the first 7 ribs right now, because these are known as the true ribs. These attach via their costal cartilages to the sternum, and you may also hear them called the vertebral sternal ribs. The lower 5 ribs, so 8 through 12, 8, 9, 10, 11, and 12. 12 you can't see on the anterior view, but I'm circling 12 on the posterior view over here right now. These are termed the false ribs. So the 8th, the 9th, and the 10th ribs attach to the rib above by their costal cartilages. So you may also hear the 8th, 9th, and 10th ribs also called the vertebrochondral ribs. And then the 11th and the 12th ribs, these end freely. So these are just called vertebral ribs. And one thing I want you to notice about the lengthening of the ribs, so the true ribs increase in length from above downward. So rib number 1 is shorter than rib number 2, rib number 2 is shorter than rib number 3, so on and so forth. And the false ribs, they actually decrease in length from above downward. So as we go through the anatomy on these slides, I'm going to throw in some physiology and some pathophysiology that we've talked about in the past, just to kind of spark your memory and make sure that you guys don't forget these important pathologies that we've already discussed. So remember FSHD, or facioscapulohumeral muscular dystrophy. So in most cases, what's going to happen first is the patient's going to have asymmetrical weakness of the face, and it's going to start with that loss of the ability to blink the eye. It's usually asymmetrical. In severe cases, it can progress to symmetrical weakness, but most cases it's going to be asymmetrical weakness, and then it's going to progress downwards in the body. And one of the pathologies that we see is that wing scapula. So remember that any type of damage to the serratus anterior is going to cause this deformation of the back known as the wing scapula. And I also want you to be able to remember the nerve that innervates that muscle. As you all know, that's the long thoracic nerve, which is innervating the serratus anterior. So any type of damage or impingement to this nerve can result in weakening or paralysis of the muscle. And then also the humerus and other long bones are affected with this muscular dystrophy. Let's move now into the anatomy of the rib. What you see on this picture here is a typical middle rib viewed from the posterior. So each rib typically has a vertebral end separated from a sternal end by the body or shaft of the rib. So this is the vertebral end here, this is the body here, or the shaft, and then the sternal end is what I'm circling now in orange. So the head of the rib is at the vertebral end, and it's distinguished by this twin-faceted surface for articulation with the facets on the bodies of 2 adjacent thoracic vertebrae. So you see here we have a superior aspect and an inferior aspect. These are the vertebral articular facets, superior and inferior. The cranial facet is smaller than the caudal, and a crest between these permits the attachment of the interarticular ligament. So this picture is showing basically all of the components of the typical ribs 3 through 9. Each has the very common similar characteristics, including the head, the neck, and the tubercle. So the neck is about 1 inch long, and this is the portion of the rib that extends laterally from the head. What the neck does is it actually provides attachment for the anterior costotransverse ligament along its cranial border. The tubercle at the junction of the neck and the body of the rib consists of an articular and a non-articular portion. So the articular portion of the tubercle, this is going to be the more medial and inferior of the two. It actually has a facet for articulation with the transverse process of the inferior most vertebrae to which the head is connected. And the non-articular part of the tubercle provides the attachment for the ligament of the tubercle. And what I've traced over in black, the shaft or the body, let me get the black out, the shaft or the body, all of this guy here, is simultaneously bent in 2 directions and twisted about its long axis, presenting 2 surfaces. It has an internal and an external surface, and it has 2 borders, superior and inferior. There's a costal groove for the intercostal vessels and nerve, which extends along the inferior border dorsally, but changes to the internal surface at the angle of the rib. And the sternal end of the rib terminates in an oval depression into which the costal cartilage makes its attachment. So although rib fractures can occur anywhere in the rib, they usually occur in the weakest area of the rib. So this is where the shaft of the ribs bend. This is the area just anterior to its angle. So like this area right here, that's the weakest area of the rib. The first rib doesn't usually fracture as it's protected posterior inferiorly by the clavicle. But when the first rib is injured, the brachial plexus of nerves and subclavian vessel injury may occur. Lower rib fractures can cause trauma to the diaphragm, which can result in a diaphragmatic hernia. And a lot of times the lower rib fractures are very painful because of their profound nerve supply. So it's really important for all physical therapists to recommend breathing, splinting, and coughing strategies for patients with rib fractures. So in lab, we're going to go over the intercostal muscles and the intercostal nerves more in depth. So all I want you to know for now is just the general innervation of the thoracic wall. So just know that there's 11 intercostal nerves with the ventral rami of the 12th thoracic nerve root, which is also known as the subcostal nerve. The intercostal nerves supply the innervation to the skin and musculature of the chest and the abdominal walls. And again, we're going to go over this more in depth in lab on Friday. So now we're going to move into the respiratory system. And this includes the bony thorax, the muscles of ventilation, the upper and lower airways, and the pulmonary circulation. So as you know, there's many functions of the respiratory system, which include gas exchange, fluid exchange, maintenance of a relatively low volume blood reservoir, filtration, and metabolism. And they also necessitate an intimate and exquisite interaction of these various components. So I already discussed the thorax with you all, so we're going to focus now on the muscles of ventilation. So as you know, ventilation is also called breathing. It involves the process of inspiration and expiration. So for air to enter into the lungs during inspiration, the muscles of the thoracic cage and abdomen must move the bony thorax to create changes in volume within the thorax and cause this concomitant reduction in the intrathoracic pressure. The inspiratory muscles increase the volume of the thoracic cavity by producing that bucket handle and pump handle movements of the ribs and sternum that Dr. Torres has already talked about. So the result of this bucket handle and pump handle movement basically results in this reduced intrathoracic pressure generated, and this is below atmospheric pressure. So this essentially forces air into the lungs to help normalize the pressure differences. And the essential muscles to achieve the active processes of inspiration at rest are the diaphragm and the internal intercostals. But what if we want to create a more forceful inspiration during exercise, or if we are having some type of pathology like cardiopulmonary distress? So then we use the accessory muscles to assist with inspiration. And these include the sternocleidomastoid, the scalenes, serratus anterior, pectoralis major and minor, trapezius, and the erector spinae muscles. And also when we get into some of the COPDs, the chronic obstructive pulmonary diseases, such as emphysema, you're going to see patients with this barrel chest, and they're going to be using a lot of these accessory muscles to breathe. The diaphragm is the major muscle of inspiration. It's actually a musculocutaneous dome that forms the floor of the thorax and separates the thoracic and abdominal cavities. So you can divide the diaphragm into the right and left hemidiaphragms. The right hemidiaphragm is protected by the liver and is actually stronger than the left hemidiaphragm. So the left hemidiaphragm is often subject to rupture and hernia, usually because of its weaknesses at the points of embryologic fusion. And each hemidiaphragm is actually composed of 3 musculoskeletal components, which include the sternal, costal, and lumbar portions that converge into the central tendon, which I am circling right now. The central tendon of the diaphragm is a thin but very strong layer of tendons. It's actually an aponeurosis, and it's situated anteriorly and immediately below the pericardium. So there are 3 major openings which are really important to allow for different vessels to go through the diaphragm. These include the IVC, the inferior vena cava, which is this cavity right here. I'm circling now in red. That's going to give the deoxygenated blood supply back to the heart. That's coming from all the components below the heart. The esophageal opening, I'm going to change colors here real quick. I'm going to go to yellow. The esophageal opening through the esophageal hiatus. And then this allows for the esophagus and the gastric vessels to go through the diaphragm. And then I'll change here to green and circle the aortic opening. And this opening contains the aorta, the thoracic duct, and the zygous veins, and allows all 3 of those to traverse through the diaphragm. And really important to know about what gives innervation to the diaphragm, and that's the phrenic nerve. Remember, C3, 4, 5, keep the diaphragm alive. As we breathe, the ribs have to move in such a way in order to compensate for the thoracic expansion and to optimize the amount that the thorax can actually expand. So all the ribs, when we inhale, will externally rotate and elevate anteriorly, and they internally rotate and depress posteriorly. And the opposite occurs during exhalation. So let's talk about the costovertebral joints a little bit. The orientation of the costovertebral joints are different for the upper and the lower ribs. So remember, the true ribs, those first 7, the movement of these ribs can best be seen from a lateral view. And this is going to resemble the motion of a pump handle. Whereas the false ribs, 8 through 12, have more of a bucket handle motion and can be seen posteriorly. These normal mechanics both work to best increase the thorax dimensions during inhalation and decrease it with exhalation. So these movements together, what they do is they create a pressurized system that will drive this bidirectional airflow for breathing. But how does this really influence our movement? So let's think about how movement is dependent upon managing the pressure system. So move your arms and legs. When you move your arms and legs, they're going to change the shape of the thorax. And that's also going to alter the airflow as well as the pressure within the thorax. So as the shape of the thorax changes, so does the orientation of the pelvic cavity as well as the scapula. So everything is moving around. So If we have poor rib mechanics or we don't manage our thoracic pressure well, we're going to begin to compensate and restrict our movement patterns. So it's increasingly important to be good pressure managers to avoid these compensatory movement strategies. So the ribs have been vastly underappreciated in our overall health. They can and do influence multiple body parts as well as systems, making them an ideal starting point for almost every type of injury. So hopefully by now you can appreciate this and now have a better handle on why our ribs matter in the restoration of our movement and our health. So the pump handle involves the upper ribs, which are going to elevate up anteriorly, and that buck handle movement involves the lower ribs, which move more laterally or flare outward. But please note that the costotransverse and the costovertebral joints are involved in both the pump handle and the bucket handle movements. And now let's direct your attention to some of the events that happen with the intercostal muscles during inspiration and expiration. So in inspiration, the external intercostals are going to slope obliquely between the ribs, forward and downward. And you can kind of see the orientation of the external intercostals that I'm going over right now in red. So they slope forward and downward during inspiration. And because of their attachment to the lower rib, which is farther forward from the axis of rotation, the contraction raises the lower rib more than it actually depresses the upper rib. And now let's switch gears to expiration. In expiration, the internal intercostal muscles, they slope obliquely between the ribs backwards and downward. So backwards and downward. So going in this motion like that, where I'm highlighting over in purple. And what that does is it depresses the upper rib more than raising the lower rib. So now I'm going to reintroduce some muscles that you already know, but we're going to talk about them in the context of breathing and their use as accessory muscles. So again, these are going to be the muscles that are utilized by patients with cardiopulmonary complications, and you'll see these muscles used extensively in the COPD, such as emphysema. So we're going to begin by talking about the SCM, or the sternocleidomastoid. It's this guy right here. And the SCM is really important for elevating the sternum and also helps to increase the anterior-posterior diameter of the chest. I'm going to change colors now and go over the scalenes. So you guys have all identified these on the cadavers at this point. So the scalenes, they lie deep to the SCM. They can be palpated in the posterior triangle of the neck. And there's 3 different divisions, the anterior, middle, and posterior scalenes. And these muscles function as a unit to help elevate and fix the first and second ribs. And now I'm going to change colors and highlight the upper traps. So again, not all of these things that I'm going to be talking about you're able to see, but I'll help identify them on the cadavers on things that we can't see in the pictures here, or things that aren't labeled in the pictures here. So the upper traps, these are going to help assist with ventilation by helping to elevate the thoracic cage. You've all been able to identify pec major and pec minor. Pec minor is deep to pec major. And when people get into that tripoding posture, when the arms are out and the shoulders are fixed by leaning on the elbows or grasping onto a table, the pectoralis major can use its insertion as its origin and pull on the anterior chest wall, thereby lifting the ribs and sternum to facilitate an increase in the anterior posterior diameter of the thorax, basically making the thorax bigger. And then the pec minor, this muscle really helps in assisting with forced inspiration by raising the ribs and increasing the intrathoracic volume. So serratus anterior and the rhomboids, rhomboid minor, going over here in black, and rhomboid major, traversing in black now. The action of the rhomboids fixes the insertion and allows the serratus to expand the rib cage by pulling the origin towards the insertion. So the serratus can only be utilized as an accessory muscle in ventilation when the rhomboids actually stabilize the scapula in adduction. So we're going to move now into latissimus dorsi. You guys all know where latissimus dorsi is. I'm going to go over here in purple. Latissimus dorsi. So the lats are really important for, the posterior fibers of the lats are really important for assisting in inspiration as they pull the trunk into extension. And then serratus posterior superior. This muscle assists in inspiration by raising the ribs to which it is attached and expands the chest. And then we have the thoracic erector spinae muscles, and those extend all the way from the sacrum to the skull. And those are really important for helping extend the thoracic spine and raise the rib cage to allow greater expansion of the thorax. Now let's move into the muscles of expiration, and these include all the abdominal muscles, which we've covered already, the rectus abdominis, the transversus abdominis, and the internal and external obliques. So all these muscles work together to raise that intra-abdominal pressure when a sudden expulsion of air is necessary, like when we cough. Pressure generated within the abdominal cavity is transmitted to the thoracic cage to help in emptying the lungs. Also, the internal intercostals are very important as muscles of expiration as well. And remember from earlier, I said there's 11 of these on each side of the sternum. And they are very important for expiration as well. Switching gears a bit, talking about pulmonary ventilation, a fancy way to say breathing, or the exchange of air in and out of the lungs. Please note that inspiration is an active process at rest and during exercise, and this involves the contraction of the diaphragm and the external intercostal muscles. So during forced or labeled breathing, that's when we're getting into utilizing all those accessory muscles in order to increase the inspiratory maneuver. The accessory muscles, again, they raise the ribs to a greater extent and promote extension of the thoracic spine. And at rest, expiration is a passive process. And this is achieved through the elastic recoil of the lung, as well as relaxation of the external intercostals and the diaphragm muscle. So as the external intercostals relax, the ribs drop to its pre-inspiratory position, and the diaphragm returns to its elevated dome position high in the thorax. So the pleura are the two serous membranes that cover each lung. The pleura that covers the outer surface of each lung is known as the visceral pleura, and the one that covers the inner surface of the chest wall, the diaphragm, and the mediastinum is the parietal pleura. So the parietal pleura is commonly described with reference to the anatomic surface it covers. The portion lining the ribs and the vertebrae is named the costovertebral pleura. The portion over the diaphragm is the diaphragmatic pleura, and the portion covering the uppermost aspect of the lung and the neck is the cervical pleura. And as you could guess, the one that covers the mediastinum is the mediastinal pleura. So the parietal and the visceral pleura blend with one another where they come together to enclose the root of the lung. So usually they're in intimate contact during all phases of the ventilatory cycle, being separated only by a thin serous film. So there does exist a potential space between the pleura called the pleural space or the pleural cavity. And there's a constant negative pressure within this space that is really important to help maintain lung inflation. And then within that space is the serous fluid, which helps to hold the pleural layers together during ventilation and reduce friction between the lungs and the thoracic wall. There are several different pathologies that are listed below that can affect the pleural integrity. The first is pleuritis, and as you know from medical term, anything with the itis suffix is inflammation. So This can present with pleural chest pain and abnormal pleural friction rub on auscultation, so inflammation of the pleura. Blood in the pleural space, as you can see, the prefix hemo, that's a hemothorax. Whereas if there gets air in the pleural space from a collapsed lung, this is known as a pneumothorax. And then if we get a bacterial infection that results in pus, the accumulation of neutrophils in the pleural space, this is known as empyema. So the two lungs of the body are located on either side of the thoracic cavity, and they're separated from one another by the mediastinum. And each lung lies freely within its corresponding pleural cavity, except where it's attached to the heart and the trachea by the root and the pulmonary ligament. So the substance of the lung is also known as the parenchyma, and it's normally porous and spongy in nature. And as you can see from the picture here, there's all these different segments and divisions of the lungs. But the lungs are basically cone-shaped, and they're described as having an apex, a base, and three borders. The three borders are the anterior, inferior, and posterior borders, and then three main surfaces, the costal, the medial, and the diaphragmatic. So the point at which the nerves, the vessels, and the primary bronchi penetrate the parenchyma, that's the hilus. And then the structures entering the hilum of the lungs and forming the roots of each of the lungs are the principal bronchus, the pulmonary artery, the pulmonary veins, the bronchial arteries and veins, pulmonary nerve plexus, and the lymph vessels. All right, on this slide, we're going to talk about the differences between the right and the left lungs. And as you can see, there are more segments in the right lung versus the left lung. The right lung is divided into 3 segments, where the left lung is only divided into 2 segments. And that's because of the presence of the horizontal fissure that I'm going over now in black on the right side. There's no horizontal fissure on the left lung. So that's how you can easily tell these two apart. So the horizontal fissure separates that superior upper lobe that I'm going over now in yellow of the right lung from the middle lobe of the right lung that I'm going to go over now in blue. Dark blue, navy, whatever color this is. This is the middle lobe of the right lung. And then the oblique fissure is found on both sides. So the oblique fissure separates the middle lobe from the inferior lobe on the right lung, and the oblique fissure separates the upper lobe from the lower lobe of the left lung. I'm going to trace over the lower lobe in purple on both the lungs right now. So this is the lower lobe on the right and the lower lobe on the left. All right, to make the divisions even more complicated, we can further subdivide the lobes into different segments. So let's begin by talking about the right upper lobe. So we can further subdivide the right upper lobe into the apical segment that I'm going over here in red. And then in the posterior view, I'm also traversing over the apical segment. The posterior segment, all of this, as well as the anterior segment. And you can see now I'm traversing over that horizontal fissure, and that makes up the 3 subdivisions of the right upper lobe. So this lobe extends to the level of the 4th rib anteriorly and is adjacent to ribs 3 to 5 posteriorly. Now we're going to talk about the right medial lobe, or the middle lobe. I'll change colors, I'll do this in yellow. So the right middle lobe can be divided into medial segments here and a lateral segment. Now I'm traversing over that oblique fissure. So those are the 2 subdivisions of the right middle lobe. And this lobe is the smallest of the 3 lobes. Its inferior border is adjacent to the 5th rib laterally and the 6th rib medially. And then the lower lobe can be divided into 4 different segments. The anterior basal, which I'm going over here in red, and then in the posterior view, the anterior basal segment, the lateral basal segment, the posterior basal segment, and the superior basal segment. I'm going to change colors for the superior basal segment. So the superior basal segment. The superior border of the right lower lobe is at the level of the 6th thoracic vertebrae and extends inferiorly down to the diaphragm. The left lung is relatively smaller than the right and only has 2 lobes, as we mentioned earlier. So the left upper lobe and the left lower lobe. The left lung is divided into the upper and lower lobes by the oblique fissure. So remember, that fissure is on both sides. The left lobe does not have the horizontal fissure. So this, the left lung as a whole is somewhat more vertically oriented than that of the right lung. So the portion of the left lung that corresponds to the right lung is termed the lingular segment and is a part of the left upper lobe. Posteriorly, the inferior border of the left upper lobe is at the level of the 6th rib, and the left lower lobe is at the level of the 11th rib. The respiratory tract can be divided into upper and lower segments. So in the upper segment, we have the nose, the pharynx, and the larynx. So you all know what the nose does. The pharynx is a musculomembranous tube that's about 5 to 6 inches long, and it's located posterior to the nasal cavity. So it extends from the base of the skull to the esophagus that corresponds with a line extending from the 6th cervical vertebrae to the lower border of the cricoid cartilage. And the pharynx can actually be subdivided into 3 more parts: the nasopharynx, the oropharynx, and the laryngopharynx. So the nasopharynx is a continuation of the nasal cavity, and it begins at the posterior nasal apertures and continues backwards and downwards. And the epithelium of the nasopharynx is predominantly composed of ciliated columnar cells. The oropharynx extends from the soft palate and pharyngeal isthmus superiorly to the upper border of the epiglottis inferiorly. The epithelium in the oropharynx is composed of stratified squamous epithelium. And then the laryngopharynx extends from the upper border of the epiglottis to the inferior border of the cricoid cartilage and the esophagus. And the epithelium that's found in the laryngopharynx is composed of stratified squamous cells, just like we see in the oropharynx. And then the larynx is its own entity. This is also known as the voice box. This is a complete structure made up of several cartilages and forms a connection between the pharynx and the trachea. The position of the larynx depends on the age and sex of the individual. And the larynx consists of the endolarynx and its surrounding cartilaginous structures. It's actually made up of 2 sets of folds, including the false vocal cords, which is the supraglottis, and the true vocal cords. The lower respiratory tract is made up of the tracheobronchial tree, or the conducting airways, the trachea, the main stem or lobar bronchi, the segmental or subsegmental bronchi, and the terminal respiratory units, also known as the acinar cells. And we'll talk about these on the next slide. The lower respiratory tract extends from the level of the true vocal cords in the larynx all the way down here to the alveoli within the lungs. And generally, the lower respiratory tract can be divided into 2 parts: the tracheobronchial tree, or the conducting airways, or the conducting zone, and the acinar or terminal respiratory units. Let's start by talking about the tracheobronchial tree, or the conducting airways. So these airways are not directly involved in the exchange of gases in the lungs, but they simply conduct air to and from the respiratory units. And as you can see, as we go further down, the diameter of the airway decreases. So the airway diameter progressively decreases with each succeeding generation of branching. The trachea, I'm going to go over here in dark red, is a tube that's approximately 4 to 4.5 inches long and about 1 inch thick, or 1 inch in diameter, sorry. And it extends downward along the midline of the neck and is ventral to the esophagus. And as it enters the thorax, it essentially passes behind the left brachiocephalic vein and artery and the arch of the aorta. And at its distal end, the trachea deviates slightly to the right of the midline before bifurcating into the right and the left main stem bronchi. So now we're going to move into the right mainstem and the left mainstem bronchi. So remember, this is where the pathology comes in. The right mainstem bronchus is wider and shorter than the left one, and it diverges at approximately a 25-degree angle from the trachea. The left mainstem bronchus leaves the trachea at an angle of 40 to 60 degrees and passes below the arch of the aorta and behind the left pulmonary artery before it enters into the root of the left lung. So again, on the right side, it's more likely for toddlers to swallow objects and get lodged in the apical segment of the right lung because the anatomical structure of the right main bronchus. It's shorter and wider than the left, and there's a different angle. So we also have segmental and subsegmental bronchi, and the diameter of those are smaller than the right main bronchi. And then we get into the bronchioles, and finally we get down into the respiratory bronchioles. And what's really important is I want you to understand some of the general anatomy of the alveolar ducts and the alveolar sacs. So the conducting airways terminate in gas exchange airways made up of respiratory bronchioles, the alveolar ducts, and the alveoli. So all of this area here. This is the termination of the conducting airways. So these structures together that I just circled, the respiratory bronchioles, the alveolar ducts, and the alveolar sacs, are known as the acinus or acinus, A-C-I-N-U-S, and they participate in gas exchange. So the functional unit of the lung is the alveoli. And this is the actual part where gas exchange occurs. That's really important. The functional unit of the lung is the alveoli, and this is where gas exchange actually occurs. So the acinus or the acinus is connected to the interstitium through a dense network of fibers. And there's two major types of epithelial cells that exist along the alveolar wall. We have the squamous pneumocytes, the type 1 cells. They're very flat and thin, and they cover about 93% of the alveolar surface. And then we have the type 2 pneumocytes, which are thick and cuboidal. Type 2 are really important for surfactant production. Surfactant's a lipoprotein that lowers the alveolar surface tension at the end of expiration and thereby prevents the lungs from collapsing. So this slide here is just a colored schematic to help you better visualize the differences between the mainstem bronchi that go into the right and the left lung. So again, the mainstem bronchi are going to divide into the lobar bronchi, and then they divide again into the segmental bronchi that each are going to supply a bronchopulmonary segment. So as you can see from the right side has a total of 10 segments, while the left side only has a total of 9 segments. And it's actually possible to remove one of these segments without disrupting the function of the other segments because each segment is separated by a layer of connective tissue and it actually functions as its own discrete unit. So as the elderly population of the US grows and as we all get old, we are all going to undergo these normal aging-related changes of our respiratory systems. So as you know, the respiratory system undergoes many different anatomical and physiological and immunological changes as we age. We talked about extensively in pathology the ability of the immune system to react to and respond to viral and bacterial pathogens decreases as we age. So pretty much everything deteriorates as we age. So the structural changes as we age in the respiratory system include the chest wall and thoracic spine deformities, and that can lead to total impairment of the respiratory system's compliance, which leads to having to increase the amount of work it takes to breathe. The lung parenchyma loses its supporting structure, causing dilation of air spaces. This is known as the senile emphysema. Respiratory muscle strength decreases with age, and that can impair the effective cough, which is very important for airway clearance. And once you get to about 25 years of age, the lung is fully mature. So thereafter, everything, like I said in class, everything is kind of downhill after you're 25. Aging is associated with progressive decline in lung function. The alveolar dead space increases with age, and that affects the arterial oxygen without impairing the carbon dioxide elimination. All the receptors that are located in our airways, they undergo different functional changes, and they're less likely to respond to drugs. So drugs aren't as effective as we age. You can also develop drug hypersensitivities as you age. Older adults have a decreased overall sensation to dyspnea and a diminished ventilatory response to hypoxia and hypercapnia, which makes them more vulnerable to ventilatory failure during high demand states, so during heart failure, and basically gives you an overall poor outcome or a poor prognostic outlook when dealing with respiratory pathologies. Now jumping into the cardiovascular system, I want to begin by talking about the mediastinum. We've already talked about this, but I want to get into a little more depth of the anatomical location and what we actually find within the mediastinum. So the mediastinum lies between the right and the left pleura of the lungs, and it's near the median sagittal plane of the chest. So from an anterior-posterior perspective, it extends from the sternum in the front to the vertebral column behind, and it contains all the thoracic viscera except for the lungs. It's surrounded by the chest wall anteriorly, the lungs laterally, and the spine posteriorly. So I want to talk about that third bullet point, mediastinal shift. So whenever there's a shifting of the structures within the mediastinum, it's appropriate to consider and examine on the chest radiograph in patients who have air trapped in the pleural space. So remember that pathology I talked about earlier, known as a pneumothorax, air in the pleural space. Also, if we remove a lung, known as a pneumonectomy, the mediastinum can shift. So in a tension pneumothorax or a pneumonectomy, it's really important to know that the mediastinum shifts away from the affected or the operated side. So I'm going to say that one more time. In a tension pneumothorax or a pneumonectomy, the mediastinum shifts away from the affected or the operated side. Now jumping into the heart, and as we all know, the heart's the primary pump that circulates blood through the entire vascular system, and it's about the size of your fist. So the heart moves freely and it changes its position during its contraction and relaxation phases, as well as during breathing. So as the heart contracts, it moves anteriorly and collides with the chest wall. And the portion that collides with the chest wall or strikes the chest wall is the apex of the heart. And that's termed the point of maximal impulse. So it's going to be this area right here, the apex of the heart. So this area is located around the fifth intercostal space at the midclavicular line. And I'm going to talk about the areas of auscultation in a second. You're also going to go over these areas again in cardiopulmonary, but it's good to know where they are. So I'll talk about this in a minute. In terms of ventilation, quiet resting breathing doesn't really alter the point of maximum impulse because there's only minimal excursion of the diaphragm. However, if we breathe deep, so go ahead, everybody take a deep breath in. What's going to happen is there's going to be a more significant depression of the diaphragm in an inferior fashion, which causes the heart to descend, and it actually rotates a little bit to the right, which displaces the point of maximum impulse away from the normal palpable position. So let's go down to this diagram here. Over the right second intercostal space, just lateral to the sternum, we have the area where you can auscultate the aortic impulses. Then we have the pulmonary area, which is located, so this is the aortic area just circled. The pulmonary area is located at the left second intercostal space, just lateral to the sternum. The tricuspid area is just inferior to and left of the sternal margin. And then the mitral area is located in the fifth intercostal space. And this is where that apex beat actually is. So I always remember this, if you just draw a anatomical map of the United States on the chest cavity, you can kind of remember, if you remember the orientation of the states, A for Alaska, T for Texas, P for Philadelphia, and M for Miami. So again, Alaska for aortic, T for tricuspid, P for Philadelphia or pulmonic area, and then the M, Miami mitral area or the bicuspid area. So Dr. Nuzzo is going to cover that in much more depth with you guys, but those are the general areas of auscultation. So let's talk briefly about the tissue layers of the heart. And as you know, the heart's made up of 3 different tissue layers. The outermost layer of the heart, it's actually a double-walled sac, and it's called the pericardium. The myocardium is going to be the middle layer of the heart, and it's the layer of the heart that facilitates the pumping action, and it contains a lot of those contractile elements. So the myocardial cells, also known as the cardiac myocytes, are found there, and those cells contain a large number of actin and myosin myofilaments, which enable a greater capacity for mechanical shortening, which is a necessity for the pumping action. And then finally, we have the innermost layer of the heart, which is known as the endocardium. This layer is simple squamous endothelium, and basically this tissue forms the inner lining of the chambers of the heart, and it's continuous with the tissue of the valves and the endothelium of the blood vessels. Now we're going to talk about the divisions of the heart and the chambers. So the heart can be divided into the right and the left halves by a longitudinal septum. So the right side of the heart is the side that's going to be receiving deoxygenated venous blood. So that's all the blood returning from the body. And the left side of the heart is going to be receiving that oxygenated blood, all the blood that's returning from the lungs. Each half of the heart is made up of 2 chambers. So superiorly we have the atria, the right and the left atrium, and inferiorly we have the ventricles, the right and the left ventricles respectively. So the right atrium, we're going to talk about that a little bit, and then I'm also going to talk about the right atrium on the next slide when you can see some more of the internal structures. The right atrium is going to receive that deoxygenated blood from the superior vena cava, the inferior vena cava, and the heart itself has its own blood supply. So the heart can actually perfuse itself when it's removed from the body via the coronary sinus and coronary arteries. So the superior vena cava collects the venous blood from the head and the upper extremities, while the inferior vena cava collects the blood from the trunk and the lower extremities. And as I mentioned, the coronary sinus collects the venous blood specifically from the heart. So here we're going to go into more of the internal structures that we find in the heart that basically separate the atrium from the ventricles and allow blood flow to go in that circle 8 pattern that we'll talk about in a little bit. So remember, blood coming in from below the heart is going to come in via the IVC, blood coming in from above the heart is going to come in via the SVC, and blood from the heart itself, the coronary sinus is going to collect its own blood, and it empties into the right atrium just above the tricuspid valve here. So blood is going to flow from the right atrium into the right ventricle when the tricuspid valve opens. So the tricuspid valve and all of the valves have this spider-like substance known as chordae tendineae, which anchors the valve to the papillary muscles, which I'm going to color over here in purple right now. These are the papillary muscles. So the right ventricle is shaped like a crescent or a triangle, and that shape allows it to eject large volumes of blood through a very small valve into a low pressure pulmonary system. So again, blood from the right ventricle is received via the right atrium, and you may hear the tricuspid valve also called an atrioventricular valve. You may hear it called the tricuspid atrioventricular valve. So again, we have the chordae tendineae, the papillary muscles, and the trabeculated myocardium. From there, blood is going to go out to become oxygenated through the pulmonary trunk. The pulmonary valve has to open up, and blood is going to be forcefully ejected out through the pulmonary trunk, and then it's going to go out into the lungs to get oxygenated. These are the lungs. Very poor drawing of the lungs, but just bear with me. And then the lungs are going to return blood supply back to the left atrium via the pulmonary veins. So the 4 pulmonary veins, 2 coming from the right lung, 2 coming from the left lung, they give that rich oxygenated blood back to the left atrium. So the left atrium is divided from the right atrium by this intraatrial septum. And the ventricles are divided from between one another via this interventricular septum. Basically runs out this way. So the left atrium has a relatively thicker wall compared with the right atrium, and that's because it has to adapt to a higher pressure of blood entering the chamber from the lung. So the pulmonary veins, they're very unique because these vessels, they actually don't have valves like other veins do. Instead, what happens is the pectinate muscles extend from the atria into the pulmonary veins and exert this sphincter-like action to prevent backflow of blood during the contraction of the atria. And then from there, what happens is blood goes down from the left atrium through the mitral or the bicuspid valve and into the left ventricle. And you can see that the left ventricle is much thicker than the right ventricle. The muscle is much thicker because the left ventricle has to be much stronger because it has to pump blood out into the entire body. So then from the left ventricle, blood leaves via the aortic valve, goes out the aorta, and then we get oxygenated, rich blood going out into the systemic supply. Now we're going to move into the conduction system, or the electrical system of the heart. So in a normal conduction system, the electrical impulses are going to start in the SA node, or the sinoatrial node. So it's really important for you guys to be able to trace this electrical conduction system. So again, beginning in the right atrium where the majority of the pacemaker cells are found. So the SA node is actually located at the junction of the right atrium and the superior vena cava. So the pacemaker cells of the sinoatrial node are the sites for impulse generation. So the SA node is also known as the pacemaker of the heart. So it actually makes or creates the impulses that pace the heart, hence the name. So the normal pacing ability of the SA node is between 60 and 100 beats per minute at rest. And then the impulse that's generated at the SA node travels down one of 3 internodal tracts to the atrioventricular node. So it goes to one of these 3 tracts and goes to the atrioventricular node, which is, I'm going to change colors here, circle the atrioventricular node in blue. And then the atrioventricular node is located at the inferior aspect of the right atrium, near the opening of the coronary sinus, right above the tricuspid valve. And then from the atrioventricular node, we go down, the conducting fibers basically converge to form the bundle of His, which is this guy here. So the bundle of His. And the bundle of His is responsible for carrying the impulses into the ventricles. So it actually appears as a triangle of nerve fibers within the posterior border of the interventricular septum. So all of this here in purple is the bundle of His. And then the bundle bifurcates, as you can see, the bifurcation right here, to give rise to the right and the left bundle branches that carry the impulses to the right and left ventricles. So the right bundle branch, so this is the right bundle branch, RBB. It's this guy here. Is relatively thin and has fewer branches proceeding inferiorly to the apex of the right ventricle. The left bundle branch, this guy here, the LBB, arises perpendicularly and divides into two branches or fascicles. So here's one branch here, and here's the other branch, kind of tracing over it. The left anterior bundle branch crosses the left anterior papillary muscle and proceeds along the base of the left ventricle toward the aortic valve. And both of these bundles, I'm going to change colors again, they are going to terminate into the Purkinje fibers, which I'm going over now in red. All these here are the Purkinje fibers. All those Purkinje fibers. And these fibers extend from the apex of each ventricle, and they penetrate the heart wall to the outer myocardium. Electrical stimulation of the Purkinje fibers causes mechanical contraction of the ventricles. And that's how the ventricles fire. So although the SA node and the conduction pathway have this intrinsic rate of depolarization, which causes the contraction of the myocardium, the autonomic nervous system is what actually influences the rate of impulse generation, contraction, relaxation, and the overall strength of contraction. So this autonomic neural transmission creates changes in the heart rate and contractility to allow for adjustments in the cardiac output to meet the metabolic demands. The cardiac plexus contains both sympathetic and parasympathetic nerve fibers, and it's actually located anterior to that tracheal bifurcation that we highlighted earlier. The cardiac plexus receives its parasympathetic input from the right and the left vagus nerves. So these nerves branch off the plexus, they follow the coronary vessels, and they innervate the SA node and other components of the conduction system. There's relatively less parasympathetic innervation to the ventricles, which results in a sympathetic dominance on ventricular function. Vagal stimulation is inhibitory on the cardiovascular system. It's really important. Vagal stimulation is inhibitory on the cardiovascular system. And this is evidenced by a decreased heart rate and blood pressure. The neurohormone involved with parasympathetic stimulation is acetylcholine. As you may know, acetylcholine plays a very important role at the neuromuscular junction. So at the NMJs, acetylcholine is excitatory. The heart is the exception where acetylcholine is inhibitory because it's involved with the parasympathetic stimulation at the heart. The sympathetic input to the plexus arises from the sympathetic trunk in the neck. Cardiac nerves from the cervical and upper 4 to 5 thoracic ganglia feed into the cardiac plexus. The sympathetic stimulation then releases the catecholamines, epinephrine and norepinephrine, that interact with the beta-adrenergic receptors, which we're going to cover more in pharmacology. And this causes an excitation of the cardiovascular system. So epi, norepi, sympathetic, fight or flight, excitation. And this is all evidenced by an increase in heart rate, increased contractility through a greater influx of calcium into those myocytes, and increased blood pressure, and an overall shortening of the conduction time through the AV node. And all of that makes an increase in rhythmicity of those atrioventricular pacemaker fibers. On this slide, we are going to identify some of the different vessels that are coming off the aorta. So let's begin by talking about the ascending aorta. We got the right coronary artery and the left coronary artery coming off, which we're going to be able to identify on our cadaver specimens. We have the brachiocephalic trunk or the brachiocephalic artery, which branches into the right common carotid and the right subclavian. We also have the left common carotid. Remember, the carotids are going to be 2 of the 4 main arteries that are supplying blood to the brain in conjunction with the 2 vertebral arteries. And then we have the left subclavian artery out here. So the ascending aorta, it begins at the base of the left ventricle and is about 2 inches long. From the lower border of the 3rd costal cartilage at the left of the sternum, it passes upward and forward toward the right as high as the 2nd right costal cartilage. So here we're going to move into some of the arterial supply of the heart. We're going to talk about the right coronary artery first, which is going to be this guy here. It arises from the right anterolateral surface of the aorta, and it descends into the coronary sulcus. The left coronary artery, which is going to be this guy here, it bifurcates into two branches. It bifurcates into the circumflex artery, which is this one, and the one I traced over earlier, the LAD, or the left anterior descending branch of the left coronary artery. We can see many of these structures really nice in our cadaver hearts. They're excellent specimens. We can see many of the cardiac veins, and you can definitely see the left anterior descending, the right coronary artery. We can see the circumflex artery, which is a branch of the left coronary artery here, kind of on the posterior view of the heart back here that I talked about earlier. And then the posterior descending artery, you can see real nice there. And then one of the main blood supplies to the heart in its deoxygenated form is going to be that coronary sinus, which traverses the heart right there. And we're going to finish this talk up by talking about the systemic circulation. So oxygenated blood that's injected out of the heart flows through the aorta into the systemic arteries. These arteries then branch into smaller vessels called arterioles, which further branch into the smallest vessels, the capillaries, which are primarily involved in the exchange of nutrients and gases. Deoxygenated blood from the capillaries enters the venules that join together to form larger veins that return blood back to the right heart and the lungs. Blood vessels have three layers. They have the innermost tunica intima, that's the most intimate layer, the middle tunica media, and the outermost tunica adventitia. So the adventurous layers on the outside. The wall of the artery is composed of elastic and fibrous connective tissue as well as smooth muscle. And anatomically, the arteries can be categorized into two types depending on their structural components along their wall. We have the elastic arteries, which include the aorta and the pulmonary trunk, which have a very thick tunica media with more elastic fibers than smooth muscle cells. And that's really important for them to allow for them to have a greater stretch as blood is ejected out of the heart. And then we have the muscular arteries, which are present in medium and small arteries, and those contain more smooth muscle cells within the middle tunica media layer. And these particular arteries have the ability of vasoconstriction and vasodilation as a result of the presence of smooth muscle cells to control the amount of blood flow to the periphery. As the artery becomes more distal, a greater amount of smooth muscle is apparent. Arterioles have primarily smooth muscle along their walls, enabling their diameter to be altered significantly as needed. Then the arterioles empty into the capillary beds, and the density of the capillaries within a capillary bed is greater in active tissue, including muscle. And then the last thing we have to talk about is the endothelium and the veins. So as you can imagine, the endothelial cells form the endothelium, or the endothelial lining of the blood vessel. These cells have the ability to adjust their number and their arrangement to accommodate local requirements. Endothelial cells do several important things, including filtration, permeability, vasomotion, clotting, and inflammation. And atherosclerosis is initiated through endothelial dysfunction. And then finally, we have the veins. So if you compare the veins to the arteries, they have thinner walls and a larger diameter. Veins also have less elastic tissue and hence are not as distensible. So in the lower extremity, the veins have valves to assist with the unidirectional flow of blood back to the heart. So if the veins didn't have the valves, we would never be able to get the blood up from the feet to the heart. And blood's transferred back to the heart through muscle pump activity, which causes a milking effect on the valve. So as one valve opens, the other one below closes and basically creates this milking, kind of like peristalsis, upwards so that the blood can return to the heart. And patients with incompetent valves in their veins develop varicosities in their lower extremities. So those are those varicose veins that we see. Those are because of defective valves. And also some more pathology for you all. Patients who are on prolonged bed rest, they are likely to develop DVTs or deep vein thrombosis, which could turn into a pulmonary embolism. And so it's really important to get the patient up and moving. Now let's talk about the effects of aging on cardiovascular physiology. So as you know, exercise has positive physiological effects on aging. And so because of these positive effects, the changes that are mentioned on this slide may not be evidenced in all older adults. So as we age, the left ventricular wall thickens because there's an increased deposition of collagen, and there's actually an enhanced size of the myocardial cells. The increased vascular thickness occurs, and there's also vascular intimal thickness that happens as well. So remember the telomerase theory? Telomerase is a protective mechanism or a protective enzyme that basically preserves the chromosomal integrity. So as we lose telomerase, the telomeres shorten, and again, as we lose the structural integrity of the chromosomes, then everything goes haywire. So the diastolic properties or the filling properties of the heart are generally negatively influenced as we age. So as we age, there's a reduced rate of ventricular filling, and there's actually prolonged periods of isovolumic myocardial relaxation. And we didn't get into that, but we'll talk about that more in physiology. The isovolumic myocardial relaxation is the time between the aortic valve closure and the opening of the mitral valve. As we age, it's going to become much more difficult to exercise, not only mentally, but physically as well, because a lot of times we gain weight as we age. So this increased body weight doesn't happen in everybody, but this increased body weight can contribute to reductions in the relative oxygen consumption and our VO2 max and our cardiac output. Cardiac output, as I just mentioned, decreases in the aging adult because there's basically just a low exercise heart rate and low stroke volume values.